I just want to move on to the first most exciting topic. It's my pleasure to introduce Dr. Barbara Seaworth. Dr. Seaworth is the medical director for the Heartland National TB Center of Excellence in San Antonio, Texas. Barbara received her medical degree from Washington University in St. Louis and completed the fellowship in infectious disease at the Duke. She has over 30 years of experience with the treatment of TB, including complex and multi-drug resistant TB. Barbara serves as an expert TB consultant to Texas binational projects along with the Texas border with Mexico, and a consultant with the Global TB Network TB Consortium. She's also is the co-medical director for San Antonio Metropolitan Health District TB Clinic, co-chair of the Community Research Advisory Group for the CDC-sponsored TB Trials Consortium. And she really shines there, to advance patient-centered and advocacy. And Dr. Seaworth is the professor of medicine at the University of Texas Health Science Center, Tyler, and is a fellow of Infectious Disease Society of America. And I can kind of go on and on, but Barbara has so much accomplishment, but most importantly, she is really good, wonderful colleague of mine. And I always reach out to Barbara if I have any, complex cases I don't know how to handle. Without further ado, Barbara, please.
Okay, I want to thank everyone for attending and for Masa for inviting me to speak about eliminating stigmatizing language. It's been a passion of mine for some time now, and it's always fun to talk about it. What I hope. What I hope to do today is to define stigma, discuss its impact, and then speak about Heartland National TB Center's Stop This Stigma campaign that we've had within the TB care movement, what we've done in the past, and where we hope to go with our Stop the Stigma campaign in the future. So stigma is a mark of disgrace. If you hear suspect, homeless, prisoner, addict, alcoholic, ICE detainee, even when you hear the word diabetic or liver patient or kidney patient, all of a sudden you're not seeing the individual as an individual person, but you're labeling them by their illness. They become part of a stereotype group. And oftentimes the comorbidities that our patients have label them in a somewhat negative way and induce negative attitudes and beliefs that create prejudice, even when it's not meant to be there within the healthcare system. And this leads to negative actions and discrimination. I can recall very early on working in the San Antonio TB Metropolitan Chest Clinic, and maybe 15, 20 years ago, hearing the healthcare providers shout out from behind the desk into the patient waiting room, suspect, very loudly, several times. And I go, what are they doing? And it turns out it was somebody that they thought may have infectious tuberculosis. And because it was a very crowded, small waiting room, they wanted to whisk that patient away, mask them, and put them in a private room. So that all was well-intentioned, but not, imagine everybody looking at you and you'll be called a suspect, and then they take you away. So certainly that's an extreme example of stigma, but all the other words that I used are also stigmatizing and make patients have, an uncomfortable feeling about dealing with the healthcare workers. They're supposed to be there to help them. So stigma is linked to poor health. It's associated with greater isolation, and social isolation often increases the risk for poor health outcomes. It negatively affects TB care. It often is a major contributor to delay in diagnosis. Individuals who perceive TB as a disease that is associated with being dirty or with being associated with something that they have done, that they have gotten this disease, some negative thing about themselves, are often unwilling to recognize the initial symptoms. If they do recognize the symptoms, they try to hide them, and they delay seeking medical care. And even after a diagnosis of TB, they really deny it. They really can't accept this diagnosis. So the stigma around TB is especially severe. It makes taking care of these individuals more challenging. It also makes our contact investigations more challenging. So this individual doesn't want to have TB. He doesn't want his friends or his family or the place where he works to know he has TB. So it makes it hard for that individual to share the names and the places with our public health workforce so that we can do our contact investigations. Individuals with TB and their healthcare providers also identify TB stigma as a cause of non-completion of care. So again, a negative health outcome. So let's look at where it all began. The roots of the language change movement in TB were fairly late to occur. If we look at the elimination of stigmatizing language and the real emphasis on that associated with the HIV epidemic and publications and guides that guided clinicians and others in how to use appropriate terminology when we address those patients, none of that was there for a long time for TB. But finally, things began to change. And it started with a United Nations document that identified every word counts and came out with the first TB language guide. That was in 2012, and that was quickly followed by a paper from published in the International Journal of Tuberculosis and Lung Disease, in which a number of very respected TB clinicians and academics got together and published this call for elimination of stigmatizing language and to center more on patient-centered care, and noted that much of this language seemed to put the blame for negative outcomes on the patient themselves. And they really concentrated on 3 words: defaulter, suspect, and control. In that same year, the global TB community, especially many of the activists, wrote an open letter to the International Union for TB, asking them to eliminate stigmatizing and criminalizing language from global TB discourse. They asked them to not accept abstracts or manuscripts with stigmatizing language in them without asking the authors to eliminate that first. This was then followed by a call from civil society through the CRAIG group, the Community Research Advisory Group of the TB, which is an advisory group to the TB Trials Consortium. And that group, which I'm a member of, wrote also to civil calling for the retirement of stigmatizing, criminalizing language, to the TBTC itself, to CDC, to the National TB Controllers Program, and many others. And that same year, we started at Heartland our campaign to stop the TB stigma. So a lot happened in 2012 to 2015 timeframe that began to change things. So if we look at the manuscript that was published in 2012 and their emphasis on the 3 words in particular, they propose that instead of calling someone a defaulter, that we talk about a person that was lost to follow-up. Instead of calling someone a suspect, we talk about a person with presumptive TB. And instead of talking about TB control programs, we talk about TB prevention and care, which is much more patient-centered language. So let's look at these three words a little bit closer. If we look at the word suspect, and whenever I hear the word suspect, this image of the shouting out into that crowded waiting room always comes back to me. But when we talk about a suspect, that's usually not a word we're describing a friend with. It's something that we believe something has gone wrong. Someone's done something, they're guilty of something, they've maybe acted dishonestly, maybe even they're guilty of a crime or offense. And it really kind of seems like the TB community was transferring the suspicion of disease to the patient. And if you step back and think about our patients and many of the places they come from and many of the things they've experienced in the past, and how they distrust government and places like public health clinics, this doesn't help us in dealing with those individuals and assuring them that we really want to help them. If you look again at the word defaulter, it's somebody that is not doing something right. They're not fulfilling an obligation. They're not paying the money they owe. They're not showing up in court when they're supposed to. They're not if they're part of a group that it has to do a group activity, they're not doing their part. And so it really is a word that's putting blame on the individual who may not be taking their TB treatment for a variety of reasons. And then last, when we look at the word control, I don't like being controlled. Any of us, as soon as somebody starts to control me, I immediately don't want to do it, even if it's something that I otherwise would have thought would have been a good thing. So we don't want to give the idea that we're going to limit, regulate, restrict, have authority over people and their behavior. And so this is not necessarily a good word to have on the outside of our clinic as individuals come in to try to see us and get care. So how do we want to identify our patients and what do we really want for them? We don't really want to talk about them as TB suspects, just that we suspect they have TB disease. We don't want to talk about them as defaulters. We really want to note that they're lost to follow-up or they're not taking their medications right now. And we really want to provide care for them if they're sick, or help them to prevent them from getting sick if they were exposed. So if we back up a minute and look at all these different things that could be related to default, many places around the globe, there's a lack of regular, uninterrupted supply of drugs. And we're starting to hear that and feel that here in the US. I know in Texas, we really have a very short supply of rifampin, and we're trying to substitute other drugs. But that's very scary that we may not have our first-line drug or even rifabutin to offer to our patients. Many states, even in the US and many other places in the world, ask patients to buy their drugs, and they may not always be supplied by the TB program. What if that family has another medical emergency, the car breaks down, their rent goes up, the dad gets laid off, and all of a sudden, do they buy the drugs or do they buy food for their child or pay the rent? So that may be something that a patient really doesn't have much control over. Our clinics aren't always in the easiest place in town to get to. I know we're way on the outskirts of one part of town, so for the community around us, we're close and convenient, but for much of the city, we aren't. Many patients don't have a car. They may not even be able to afford a bus ticket, and it may be 3 bus changes by the time they can get to us in San Antonio. And I'm sure that situation is probably similar in other cities across our country. Our hours are inconvenient. They tend to be convenient to us, not to our patients. Most of us don't work Saturdays or evenings. And And then because the culture is different, when we get people from everywhere, we may not speak their language, we may have difficulty communicating, we may not, even if we can get the language line, we may not culturally speak their language. And so no matter how hard we try, we may be perceived as being unfriendly, and that makes people not trust us. And so maybe not want to take the medicines we give them that initially may make them feel worse. And then oftentimes they're sent from clinic to clinic to clinic to get their other comorbid illnesses taken care of, whether that's diabetes or their immunizations, HIV care. So when we look a little bit more at the word control, we really want to control TB. We don't want to control the patient. We don't want to control the community. We want to do something to help our patients. We don't want to do things to them. Although, you know, there is an aspect to TB when we have challenges getting our patients to cooperate with therapy, that sometimes we do have to be a little bit more, I don't know, forceful in or convincing in trying to get our patients to remain isolated if they're infectious, or to take their medicines. And one of the things we do in Texas that I think is really hard is everybody gets a warning letter where they're warned what will happen to them if they don't you know, remain in isolation, if they don't take their medicines, if they don't come to see the doctor or get their labs. So that is also says TB control up front, and then they get this warning letter. That really bothers many of the patients that I see when I talk to them and they ask me about it. So I don't know what we can do about that, but I think that's outside of my control right now. I'm working on it. So if we look at the call from civil society, they really wanted to be involved in this work to end stigmatizing language in TB. And they wanted to make sure that everyone knew how powerful language was, and that it involved a number of leaders, people from civil society, researchers, health professionals, academics, to really eliminate this stigmatizing language and begin to change how we talk to patients about TB. Blessy Kumar was really important in this movement early on, and she addressed how it shouldn't be me, the doctor, or you, the researcher, that are the primary people that are trying to direct how to influence this decision about tackling stigma, but it should be the affected communities themselves. And she also pointed out that as long as we think about TB only as a biomedical or a medical diagnosis, that it is going to be really hard to end TB, because there are so many social things around TB. And we all know really TB is a social disease. So getting to Heartland Stop the Stigma campaign, I remember when I look at this picture, we launched this campaign at the National TB Controllers Association meeting in 2015. And at that time, there was really a reluctance, a lot of pushback to getting rid of that word control, not as much to the word defaulter or suspect, although everybody said, but you have to write out 3 or 4 words instead of just write out suspect when you're writing your note. This was probably before a lot of us had electronic medical records. But I was nervous as we launched this campaign, and we're really committing to push and push hard to get people to eliminate stigmatizing language. And I was so heartened to see all the people that were coming to the Heartland desk and supporting us in this effort. That's not to mean that everybody supported us, but many people did, and it made it so much easier to go forward. And this is just in the initial days. These were pledges that were signed by people that were at the meeting, pledging to work with us on this. This is Dr. Jane Carter on the right in the screen, and she noted that by using non-stigmatizing language, we can begin to break down some of the stigma associated with TB. It's going to take more than that, but this is certainly a beginning. So Heartland committed to use language that was patient-centered, appropriate, sensitive, and recognize the dignity of the people we were trying to help, as well as their families. To implement the use of non-stigmatizing language in all of our published materials, our products, our posters, our marketing materials, and whenever any of us gave a presentation elsewhere. And then to promote the use of non-stigmatizing language by working with people who spoke for us to make sure that their presentations were free of words such as suspect, TB controlled, defaulter, non-compliant, and TB case. This was a letter dated, one of our first letters that were sent out in June of 2015, asking our speakers to collaborate with us in this effort. And really, we really got a lot of very positive feedback on this, and not nearly as much pushback as we thought we were going to get. So this is me back in 2015, noting that, you know, I too had created or contributed to the stigma, even though I so wanted to help my patients, that I had used this language as well, not recognizing how it hurt the individuals that I worked with. And this is 2015, and you can see that it's been a while, and I'm still working on it. And I guess I'll look a lot older, hopefully before I'm done working on this, but maybe we'll eliminate stigma. I think there's so much work still to be done though. So where are we with changes to our language culture and TB care? This is one of the first products that we developed, a fact sheet that said, instead of use this, instead of that, use a person lost to follow-up instead of defaulter, for example. And this was just for health departments or clinics to put on the wall to help them remember. This was an effort that was supported by the Treatment Action Group, as was our ability to produce these t-shirts and hand them out. We handed them out across the country to anybody who would pledge with us to eliminate stigmatizing language, and also to challenge one other patient or one other TB program to also commit to stopping the stigma. So most of these t-shirts are now pretty faded, but we're thinking of coming up with version 2. Every time we did a training, we took a little bit of time in the beginning of that training to talk about stigma and its negative impact, and to encourage people to avoid stigmatizing language. And this was, we worked with patients at our clinic and our hospital that are right here on our grounds as we developed this stigma campaign. And this was one of the patients at the hospital, and she noted, and we put this on the placard for her, "I'm a patient living with tuberculosis and I need prevention and care. I am not a suspect who needs to be controlled." And so she felt pretty strongly about this. So we had some very positive testimonials from our campaign, and noting that people were implementing these changes and believed in them. As this was right after our initial campaign, we had 206 pledges from 27 states and 3 countries, and from people who are committed to helping us with this campaign. And then about a year after we started it, we looked at what were longer term effects, and we noted that 56% of our respondents had actually witnessed instances and occurrences of stigma negatively impacting patients. 86% had changed their language or were working hard at it. 69% of our presenters and speakers now routinely reviewed their presentations for stigmatizing language. 54% of respondents viewed the eliminating stigmatizing language video, and 63% noted that viewing the video impacted their pledge. And I can tell you that we had pushed on CDC and the Division of TB Elimination, as well as the TB Trials Consortium. And now there's a publications committee within the TBTC, and I'm a member of that. And every single publication gets reviewed for stigmatizing language before it's sent to CDC clearance. The protocols now are also being reviewed by CREG members for stigmatizing language. The CDC has removed stigmatizing language from many of their recent fact sheets and from their new TB guidelines. So that's a major improvement. And so where are we going? CDC is also recognizing the importance of people first language in dealing with comorbidities, that many of which may affect some of our patients. This was just one in how to deal and communicate about people with disabilities. And so instead of talking about somebody as being blind, you talk about someone who's visually impaired or who may be blind. It's a patient who has, a patient with, rather than just labeling them by their diagnosis. The National Institute on Drug Abuse also recently, I think this was 2 years ago, published this fact sheet on how to, what terminology to use when you're dealing with individuals who are experiencing addiction. And so you should never talk about somebody as an addict, but somebody with a substance use disorder. Shouldn't talk about a habit, but a drug addiction. Shouldn't talk about abuse, but rather they used a drug or they misused a prescription drug, and certainly not talk about an addicted baby, but rather a newborn exposed to substances. They also noted that the word dirty was not something that should be used for screening purposes, talk about testing positive, or talk about a person who uses drugs. And if a person right now is testing negative, that should be the terminology rather than they're clean, because as we all know, this is a lifelong effort that individuals who struggle with addiction have. And so, we don't want to talk about them being clean, but rather testing negative, or we could talk about them being absent from drugs when we see them. So where does the stigma come from? It comes from inaccurate beliefs, old beliefs, and especially that addiction is a moral failing rather than a true disease. And so the stigma associated with addiction really affects people with substance use disorders. They feel stigmatized. They don't really want to seek out treatment. They feel that the stigmatizing language leads over to healthcare providers' perceptions and how they treat people who are experiencing substance use disorders. So changing the way we talk about people can begin to change how we think about people and how we care for them. So if we're currently in a refunding cycle right now, we're busy writing our grant, but if we are refunded, we hope to work harder on expanding our Stop the Stigma campaign. We know there are many individuals coming to us from whether it's Afghanistan, the Ukraine, or people coming from everywhere across our southern border. Many of these people have so many things that if we don't speak correctly about them can be stigmatized, can feel very stigmatizing, and they have many other difficulties to deal with, and they don't need for us to be using stigmatizing language. So trying to develop that, we're trying to redo our stigma calendars in the future, but I just want to end with thanking you for your attention, thanking you for your interest in this topic and asking me to talk. And this is just from the original campaign, a number of individuals who signed our pledges. So I want to end here, and I don't know if I have time for a few questions. So thank you again.